sure we get started so we can give our speaker enough time. It's my pleasure to introduce Dr. Joanne Elmore. She went to medical school at Stanford and then did her internship and residency at Yale before getting her MPH as part of the Robert Wood Johnson Clinical Scholars Program. She got her infectious disease fellowship and joined the faculty at Yale before coming to our department for epidemiology and becoming the associate director of the RWJ Foundation Clinical Scholars Program here. She serves on the editorial board for several journals and is a reviewer for dozens more. She's been on many national committees, mostly focusing on cancer screening and epidemiology, and has been named on a large number of grants, publishing hundreds of articles in all of the usual impressive and prestigious places. Throughout her educational and professional journey, she's collected a number of honors and awards, several notable for me, including her achievements, recognizing her achievements as a woman in medical research, as well as an NIH Merit Award in recognition of her work in developing evidence-based cancer information for both patients and health professionals. While her focus has primarily been on her research, she also received last year's John Q. Sherman Award for Excellence in Patient Engagement. As I looked at her CV, she also has listed, she has mentored many of the people who I respect most within our department, including me, which was a real pleasure. We got to work together on a project. Working with Dr. Elmore is an exercise in constantly running across all of the new, exciting questions that one could answer as you talk about just about any topic. It is my pleasure to hear about her opinions on our new OpenNote program.
Thank you. 3 weeks ago, I received an email asking if I'd give this talk. And I was skiing in Sun Valley, and I said, sure, what do you want me to talk about? And they said, OpenNotes. I want to start by just pointing out that our healthcare system generates 1.5 million records and encounters every year. And these records are now available to patients. I should start by explaining what in the world is OpenNotes. OpenNotes is basically a simple mechanism where we are inviting patients easy access to their own medical records, similar to electronic banking. And I'm actually hearing a little bit of sound back at me. Is the sound okay for you guys? Okay, because it's pretty loud right here. I have to start with the usual disclosures. Our research was funded by the Robert Wood Johnson Foundation. I have no other financial investment or disclosures. I will make one other point, though, and I didn't put it on here in writing, but I'm not an IT person. I'm not a bioinformaticist. I'm a physician. I'm a clinician. I see patients. I actually do not like our current outpatient electronic health record. For those of you at Harborview that see patients with me, you know that I have been known to hit the computer screen and use a few unprofessional words when I'm trying late after clinic to finish the clicking. I'm not certain our medical records are improving the quality of care that I provide to my patients now. I have hopes. I'm always an optimist. But I wanted to add this disclaimer that I'm not an IT person. And in fact, Tom Payne is here, and I've asked us to give him a microphone so he can answer all your questions afterwards. When I was invited to get involved with OpenNotes, I agreed for 2 reasons. One, it just made sense. It seemed like this is where we were going. Secondly, they asked me if we could do a study with the Harborview patients. I care about our vulnerable patient population. I do not want to have a new digital divide. I did not want our patients to be left behind if this is the way things are moving. And so I agreed to get involved in OpenNotes research, even though my research is in cancer diagnostics and accuracy. As a time-honored tradition in medical grand rounds, I'd like to have us start with a patient vignette. And if I can get this to work, this is a patient who is seen in the Boston area, and he has used OpenNotes for 6 years.
OpenNotes is it allows me to continue my conversation with doctor after our annual or more than annual meetings are over. I find there are a lot of facts that have escaped me in those meetings. And that's why open notes are such a great idea for me, because I can re-experience the event with my doctor and process what went on. I think one of the not so apparent but real values is that people will share them with others. They will be able to have much better communication, much better conversation with their loved ones, with other professionals. And I think that getting a family involved in a patient's illness, or even just managing a life of healthcare, is tremendously important. I can see a day where involving the patient in the very production of, writing of open notes, not only improves the quality of the information, but improves the quality of the treatment.
This patient, Mr. Meltsner, actually, he has a JD degree. He's a law professor in Boston, and he has published in Annals of Internal Medicine and recently in BMJ about his perspective of open notes. He's found errors in his medical records that he's asked them to amend, and he became quite ill a few years ago. He found it very helpful for his wife to have the information. This map shows the very rapid implementation of this open notes, open medical record for patients in the U.S. 2 years ago, we published on 19,000 patients at 3 health systems. Within 2 years, there are now 4.8 million patients that have access to open notes. In our own region, VM last year flipped the switch. All their patients have access. Group Health didn't want to be left behind, so Group Health is now in the process of transitioning all of their clinics to open notes. Swedish heard about what we're doing, probably with an IT upgrade next year. They'll implement it. Kaiser Northwest down in Oregon has implemented it. All of the little dots, those are the VA. The VA system, they're not quite known for their technological innovation with web-based medical records. They implemented a little blue button so the vets can sign up in person and gather their medical records from wherever they are. This lists some of the U.S. health systems that have implemented open notes. After one of our publications, the CEO of MD Anderson called us and said, gee, you've published on this. We've been doing this for 10 years. At MD Anderson, they provide care for very sick cancer patients who then go home to a long distance, and they wanted both the patients and the providers to have access to those medical records. In addition to the U.S. open notes, this is happening internationally, especially in countries that have a more organized healthcare system. In Sweden, they're developing a patient portal. In Estonia, they developed a countrywide patient portal 8 years ago. I decided I wanted to cover the following 4 topics. Now that I've explained what open notes is and why it's important, I want to step back in time and think through the history of our medical record. I'll then describe our prior research on open notes, describe what is available here for our own patients, and then conclude with some thoughts on open notes. Stepping back in time to 1887, you see a very caring physician at the patient's bedside, pondering the clinical history and the differential diagnosis, caring parents in the background. When this physician wrote a clinic record, it was probably used only by that single physician. And it was meant to remind him of the patient's status, what his thoughts were on how to provide care to that patient. And the notes at that time looked exactly like this. Some things don't change, our penmanship. Over 100 years, the records have morphed into something such as this. Less richness in narrative, completely lacking in the little box that's social history, lacking in the family history, and the use of abbreviations and templates. Now, the medical record has become more and more complex over time. As patients are seen by many physicians and many different health systems, we need to both communicate with ourselves, but now with other doctors. I need to write a detailed note so that other physicians taking care of my patients can also do a good job providing care. In addition to just communication among and between physicians, though, we now have billing and compliance and all that other paperwork that comes in, and we now fill vast warehouses of the paper medical records. Historically, patients were not invited in to look at the medical records, but sometimes pop culture gives us an inkling of what patients are thinking. And so let me share with you a Seinfeld episode. It's not very flattering of the physicians, and I'm sorry to say.
Difficult.
Elaine, you shouldn't be reading that. Now tell me about this rash of yours.
Well, it's, you know, I noticed that someone wrote in my chart that I was difficult in January of '92, and I have to tell you, I remember that appointment exactly. You see, this nurse had asked me to put a gown on, but it was a mole on my shoulder, and actually I specifically worn a tank top so that I wouldn't have to put a gown on. You know, they're made of paper.
Well, that was a long time ago. How about if I just erase it? Now, about that rash.
But it was in pen. Fake erase.
All right, Miss Minnis. This doesn't look too serious. You should be fine.
What are you writing? Doctor? You know, I'm not going to believe what happened to me at the doctor's office today.
Not the gowning.
No, I was looking at my chart and it said that I was difficult. Why would they write that?
They've gotten to know you.
And then the doctor writes more stuff down there and he doesn't even look at my rash.
Why don't you find a doctor that doesn't know you're difficult? Elaine, you really didn't have to put on the gown.
Oh, it's my pleasure. I love these. You know, and in fact, I've got one at home. It's perfect when you just want to throw something on. Hi.
All righty. Let me just review your history before we begin.
Oh, where did you get my chart?
From your last doctor. Standard procedure.
You know, I can tell you my whole history. Let's just...
Okay, let's take a look. Well, that doesn't look too serious. You'll be fine.
Oh, geez, but it's really, really itchy.
This shows a paper chart. Around the time of the Seinfeld episode, we were all in the process of learning about this electronic health records. So again, thinking back historically, I want to share with you 50 years ago in New England Journal of Medicine, there was an article about electronic health records. And it had these two images in the NEJM article that I want to share with you. They had 50 patients, and the patient on the left is entering data into what is described as a small digital computer. And then she is looking at what's called a cathode ray screen on the right. And it asks about her allergies. And she types in a 1 if it's a yes, 2 if it's no. And the goal of these investigators was to see whether we can engage patients in their medical records, whether we can get their help and have them enter standardized, complete information and offload the work of the physicians. There was a quote in this paper that I want to share with you, and it's the following. Neither the method of history taking and recording, nor the reliability and usefulness of the data collected has been studied as rigorously as the other tools of clinical medicine. This was 50 years ago, and they pointed out that we're doing a terrible job studying our medical records, how to make them useful for patients. Sadly, I think we're still in the same boat. 50 years later. This is a screen. I took a screenshot last night from my computer. I love Mindscape. This, when I moved here 15 years ago, is easy to use. It's intuitive. It gives me all the information on my patient. And it has this really cool link on health links, so I can get evidence and data. some of you may not realize that Mindscape that we use every day, in fact, even though they've spent hundreds of millions of dollars on other electronic health records, more than 90% of providers use Mindscape every day. It's our internal sort of glue that keeps our machinery moving forward. You may not realize how historical Mindscape is. A publication in The Lancet in 1998 described Mindscape. Members of our department published this article, and they described how it was web-based, and they developed it as a regional resource for all the WWAMI doctors. And they described how they took care of a patient at Harborview. The patient would go back to Ketchikan, Alaska. They would give that patient's doctor access to the one patient's medical record. And they had quotes from the doctors saying, "Oh, Mindscape, this is the best thing since sliced bread." And another quote in their little piece about how this is going to transform my practice. Well, the first author of this was Harold Goldberg. And sadly, he suffered an early and untimely death in 2006. But his legacy lives on. He had started a decade ago inviting patients to read their Mindscape notes at the Roosevelt Clinic, the adult medicine clinic over there. These were diabetic patients because he wanted to engage them, and he thought this would help them take better care of themselves. Then a few doctors here at the UW who worked in the transplant clinic realized that they provided care for really complex patients, and it might be helpful for their patients. They would give them access to Mindscape, just to their own medical records, and then the patients would have their transplants and go back home and would be able to know a little bit more about their medical history. So unbeknownst to all of us, for a decade, this has been happening, even within our own system. This brings me to part 2. I'd like to describe some of the very simple, easy research that has been done to date by the OpenNotes Research Group. It's a collective of many investigators who are listed here, Harborview and the UW, and the national collaborators are listed on our website. Before I agreed to do research on OpenNotes at Harborview, I thought we needed to step back and make certain our Harborview patients were ready for this. So we did focus groups. Shrisha Dani Reddy took the lead in this paper. And focus groups are basically a qualitative research methodology similar to being a cultural anthropologist. We step back and just listen to patients. And the first thing we heard was some of them didn't even realize we were writing notes. When we explained the idea of OpenNotes, and explained it's similar to electronic banking, then they said, "Oh, that would be really great." And they listed all these positive benefits. It would help my knowledge. It would be really convenient. They felt it would give them a sense of empowerment. They also thought it would help and give them a stronger relationship with their doctor if they were more engaged. The patients in these focus groups, though, also voiced concerns, and I've listed them here. They were really worried about privacy, understandably. They were worried that they wouldn't be able to understand what we wrote. They had a fear that the computer would replace the direct provider contact. And then finally, these patients at Harborview care so much for their doctors, the residents and attendings who take care of them. They all articulated a concern that this OpenNotes would put too many demands on their doctors, and they cared about their doctors, and they were worried about that. At the end of the focus groups, we just opened it up and said, what would you like to see in OpenNotes? And they were like kids in a candy store. They had all these great suggestions. And one of them I've put here because I think we still need to do it. They said, well, we may not understand what's in the notes. Can you put a little hyperlink so that we can click on it and it'll bring us to credible patient information, something that we trust? So that's still on my wish list. I think we need something like that. Well, after realizing that our patients were gung-ho and wanted to go forward with this, we then instituted a series of studies, and I'm just going to describe the main one. We've had a few publications in Annals of Internal Medicine, and the design was quite simple. We surveyed patients and providers at 3 different sites. We then flipped the switch and allowed all the patients access to their notes, their doctor's notes, and then at the end of 12 months, we surveyed both the patients and providers. The 3 sites were at Harborview, the Adult Medicine Clinic, and Madison Clinic. We gave the patients access to Mindscape. The second site was Harvard, Beth Israel. They had their own homegrown electronic health record. Most of their patients had PhDs. And then the third site is Geisinger, rural Pennsylvania, and they had Epic, and they had a patient portal through Epic. I asked 3 study questions. The first was, what do the patients think about this? Will it help them? The second is, what about the doctors? Is OpenNotes the straw that breaks the doctor's back? And the third question was, after 1 year, what will people think? Will they want to continue with it? From the patient's perspective, they were very enthusiastic. More than 90% of patients actually read their doctor's notes at the 3 sites, and I was surprised that 1 out of 4 patients actually shared their access with a family member or a caretaker. And it was much higher at Harborview, mostly because of the Madison Clinic. The HIV patients really wanted to share their access with their partners. The patients reported a lot of benefits. We had survey questions, and 70 to 80% of the patients agreed or strongly agreed with questions such as, because of OpenNotes, I feel more in control of my health. I think I have a better understanding now because I can read the doctor's notes. Or, I think I'm doing better taking my medications because I could read that note and it listed the meds. I was surprised that at the end of the year, the patients, when we asked them, well, what about things like, were you confused? Were you more worried? Were you offended by what we wrote? That the percentages were quite low. 4% said they were confused. But remember, there's a lot of limitations. This is just self-report. We don't really know what they comprehended. The bottom line for patients then, after 1 year, 99% of them said on the survey, we want this to continue. We think it's great. It's helping us. We had an additional survey question that I describe here at the bottom of this slide. We asked the patients, and we had 19,000 patients, we asked them, given a choice of doctors or health plans in the future, would the availability of OpenNotes influence or impact your choice? And 4 out of 5 patients said definitely. I actually think this one survey question was very important in lighting a fire and speeding the implementation. You saw how we've gone from just the 19,000 patients that we studied to almost 5 million in just 2 years. I think hospital CEOs paid attention to this. There's a lot of market competition in our healthcare system. Now I want to show you a slide that was published in Annals that gives the results for both the patients and their providers. And I'm going to walk you through this, if I can even read it. On the bottom left are the results for Harborview. They list the 6 questions, and these are all about benefits. Things like, I take better care of myself, I remember my medications, I feel more confident communicating with my doctor. So all of these are like positive things as a result of OpenNotes. The circles are the percentage of patients who agree or strongly agree that that's going to be beneficial from OpenNotes. The boxes are the doctors. And you notice the trend here. It's pretty obvious. The patients are, 80% say, oh, I agree. OpenNotes has these 6 benefits. The doctors were more, 30 to 40% of the doctors remarked positively on those survey questions. Now, I'm going to open up and show you the rest of the data. At the top are the results of the Harvard patients and Harvard doctors at Beth Israel. And then in the middle are Geisinger. And you can see the similar trend. When we asked the doctors at the end of the year a list of questions, one of them was, do you think you're changing how you're writing the notes? And 1 out of 4 said, regarding mental health issues, yes, I'm slightly altering the wording and how I'm couching things in black and white. For substance abuse, 20% said that they had changed, and for obesity, 10%. I've listed the percentages at Harborview because you'll note that they're smaller. I don't know if that's because we're already more sensitive in what we write or if we're more comfortable, but it was much less at Harborview. I should add, there's a lot of limitations to these studies. One is that at Harborview, we had very few patients enrolled. At the other 2 sites, they already had 80% of their patients enrolled in the electronic portal. Their patients were already emailing the doctors. Their patients already had access to radiology, and they just opened up the doctor's notes. We didn't even have patients enrolled at Harborview. I didn't know if our patients even had computers. And so we only had a few hundred patients of the 19,000. And because of this, I think the physicians, we weren't impacted. I only had 2 patients that were enrolled. The patients, though, even if they are homeless, they can go to the library. Even if they didn't own a computer, we had one elderly grandmother that really wanted to participate. She was on 17 medications, and her 7 grandchildren chipped in and purchased her first computer. And she brought it to our little orientation where we signed up the patients, and we had to help her take it out of the box and explain to her what a mouse was. So our patients loved it. I think the data from the physicians, at least at the other 2 sites, it gives you an inkling that it is changing the way physicians are practicing. Now, this was important to me. This shows workflow and the impact on our schedules. I was very worried about this, so I'm going to show you the data pre-intervention at the baseline survey, and then on the right, the physicians' responses after the year of OpenNotes. And the 2 survey questions are, do you think OpenNotes will have you spend more time answering all those patient questions outside of clinic? In other words, you write your note, you've submitted as final, perhaps an email prompt goes to the patient, at least at the other 2 sites, saying the doctor's note is available, the patient clicks, reads your note, then the patient has all kinds of questions and starts emailing and calling. And before the OpenNotes study, 42% of the doctors said, I agree that this is going to be a problem. And when we asked, do you think you're going to spend more time writing and editing your notes because of this? 39% beforehand said yes. After the intervention, the percentage went down, just 3% and 11%. And it was reassuring to me that the percentages at the other 2 sites where the doctors really had 70, 80% of their patients reading the notes, they were very, very low. The bottom line for the doctors at the end of the 1 year are the following. At Harborview, it wasn't a big deal for us because we had so few patients. Because of our IRB study, we had to close out according to the rules and regulations of our human subjects. But this was around the time that we were going to transition to EPIC, and so I felt like it was okay. The patients didn't feel it was okay. Some of them complained, and so we said, if you really want, we can sign you up still. And a few patients did, but we waited. And then lo and behold, even I was surprised that the entire UWP, last October, we now have OpenNotes for every single one of all of our patients. At the other 2 sites, Beth Israel and Geisinger, every single doctor wanted to continue. None of them opted out, and they actually offered it. Unbeknownst to us, during the year-long study, something happened at one of the sites. This shows on the y-axis the percent of patients that actually click on and read a note within 30 days. And this is for, in red, the Harvard site, the Beth Israel, and in blue, Geisinger. So unbeknownst to all of us, at one of the sites, one of the IT guys turned off their email prompt to the patients. They were sending email reminders to the patients to say, you've got a new note, go to your OpenNotes. And what happened was an immediate drop in the percentage of patients at that site that read their notes. Very simple. I think it's to be expected. If you don't give them a reminder, they won't read it. So if any of you are sitting here starting to get worried that your patients are reading your notes, I can tell you that we are not sending out email reminders, and our percentage is quite low currently. I think that this is something that they probably will study, and it may vary by clinic whether they want to send out email reminders or not. Around the time of our publications, I was approached by faculty in our UW ophthalmology department in that they heard about what we were doing, and they wanted to engage their eye clinic patients, and they wanted to institute OpenNotes in the eye clinics. And this was a couple of years ago. And I thought, and they wanted to do research on it. And so I helped them do research, and they surveyed 500 patients at all their different clinics here and their beautiful new clinic at Harborview. And all 500 patients said, oh, this sounds great, we want to do it. And Brian Lee, this assistant professor, said, we need to do this for our patients. You'll notice that he has a JD degree. He has a law degree from Harvard. So I said, well, how about if we take advantage of all your legal background and have you review the literature on OpenNotes? Think of it, all the HIPAA regulations, they were all developed when we had paper charts. And so we're entering new territory, and there are a lot of issues that I think are yet to be decided. So he's working on that. In addition, when he first proposed this idea to me, I don't know if any of you in the audience had the same reaction, but I thought, the eye clinic wants to be the first clinic to do this? Okay, this is what the eye clinic notes look like. And when I pointed this out to Brian, he said, yeah, our notes, we have a lot of abbreviations. And then he even went on to say that they don't all use the same abbreviations. That within his department, they each use different abbreviations between, facilities. And so I said, can we just study this? And it was very simple. We basically did a survey. We took 2 real iClinic notes. We showed them to Harborview faculty, and we gave them a Likert scale from 1, I don't understand this, to 10, oh yeah, I understand this. And let me just show you the results. The Harborview docs, they're honest. 1 or 2. We do not understand their notes. Now, I think that as we now have OpenNotes, not just in the iClinic, which they wanted, but everywhere, that the ophthalmology department has more work to do than we do. But I also think that just as when we look at their notes, how they're confusing, this may be the feeling that patients get when they look at ours. We have all kinds of other research. We've got great pilot data if anyone is interested in writing grants on the topic. I was interested in the fact that so many patients are concerned about privacy. We've had medical students work on the issue of patient confusion after reading their charts. I think it's very cool that we can now develop a portal so patients can share the records. I would love to have access to my 90-year-old mother's medical records. She lives in California. Things like this would be helpful. We've studied the HIV patients and how they really want to get engaged in their records. But I do need to add a summary of the research, and this is important in that the data are limited and there are a lot of limitations. Let me move now to the third part, which is what is happening locally with OpenNotes. At the VA, I've already mentioned that they now nationally have a blue button that patients can sign up. They have to do it in person, and they click on the blue button, and they can read their notes. I just heard that Seattle Children's is thinking of developing OpenNotes for their patients. There's an interesting legal issue that they're going to have to deal with in pediatrics, though, and that has to do with teenagers. It is a matter of state law whether teens are allowed access to their medical records. 21 states in the U.S., by law, teenagers have access to their records. And I know about this because I have a teenage boy. I have to bring him in to get his annual physical exam so he can participate in all the sports at his high school. And he knew about my OpenNotes. And so my kid said at check-in, hey, can I sign up for that OpenNotes thing? And this was at Virginia Mason. And even though they have it, they said no. He said, why not? And they said, because you're a teenager. And he's like, yeah, but I know how to use a computer. And they're like, you still can't. And so this is going to be a really interesting learning experiment. I can tell you that at UCLA, they are implementing OpenNotes over the next year. And one of my colleagues has a daughter with diabetes, a teenage daughter. And her daughter has access to her records, and her daughter doesn't want to share it with her mom. So I think that we have a lot to learn. For the other 2 sites, it's easier. At the UW Medical Center and at Harborview, patients are provided access. This has gone through many committees. I'm sure they've had long discussions before they rolled it out. Very positive support from Mika Sininen, our president of UWP. They developed these flyers they wanted posted. And this is a brief summary. I show in the middle column the inpatient, Cerner, and on the right, Epic. So for the inpatient, last summer, they started offering an OpenNotes sort of website. It's only the discharge summaries. It's via an online portal. When patients are hospitalized at either of the hospitals, they can be signed up. And supposedly you cannot hide these notes. For the outpatient, October 21st, they flipped the switch. And any patient that's signed up for the eCare portal can now access their notes. For both of these, this is only going forward. So don't worry about the notes you wrote 5 years ago. For what is visible, here, the UW decided every single clinic, which surprised me because at Harvard, the psychiatrists didn't want their notes available. But here, the psychiatrists wanted. In fact, they want to study this. I did put at the bottom whether you can hide a note. And let me just mention this because I think physicians often wonder, don't I have a patient with a borderline personality that this might disrupt them and it might be bad for them, actually, to read their notes. You can supposedly block the patient from viewing. I've heard various things that you type in. Most recently, they told me for reason for visit, you type in sensitive note. This is what the portal will look like if a patient goes into the eCare. It basically says, which hospital and medical system did you receive care. They click on it. It could be Hall Health. It could be Harborview. It then pulls up a very simple screen, and they can click on the radiology reports, they can click on their labs, they can click on pathology reports, and they can read all of our notes. For the fourth part of my presentation, the faculty at Harborview have been very thoughtful as we have experimented with OpenNotes with our own patients. They wanted me to conclude and share with this group some of their thoughts on how they're using OpenNotes in their own practice. As Confucius says, without knowing the force of words, it's impossible to know more. We're moving into a totally new era. We all learned how to be physicians, how to be careful with our wording, how to talk with the patient, how to be present with that patient. We learned about the power of our placebo effect and the way we modulate our tone of voice, the way we word things. Now we have added in yet another potential tool to help us take care of patients. It's a complicated tool. I'm not certain we know how to use it yet. So these are some of the suggestions from the Harborview folks, and I look forward to any other suggestions from the audience at the end. They kept telling me to try to write the notes with the patient, and I didn't do that for quite a while. I'm a recent convert. In fact, I would not do this, which the doctor is doing. I turn the screen, the patient looks while I'm typing. They invariably will point out my typos. And I think this is helping me. I've started billing by time because I'm spending the time with the patient. They see all the work I do. I used to sort of see the patient, go home, have my handwritten scribbled notes, and spend Friday nights finishing my charting. Now I'm doing it with the patient. They are more engaged. And in fact, this summer, we have a UW medical student who worked for Epic for a few years. And he is going to help us do a project this summer where I'm going to have the patients help to write the note. When they come and check in, our medical assistant will get their vital signs, and the medical assistant will sometimes talk to them for 10 minutes. I can hear the patient going on with all the things they want to have covered in that visit. Maybe 15 minutes with my medical assistant. Then the assistant will put the patient in my room, and before I go to see the patient, I'll look under what the medical assistant charted. Back pain. That entire 15 minutes, the patient thinks that I know that information. I have no idea. So we're going to have patients come in and type what they want to have accomplished at that visit. It'll be interesting. You know, some of them may go on for 5 pages. Maybe that'll be diagnostic in and of itself. The second overarching tip that was recommended by our faculty is to think about our language. The wording, be careful, use supportive words. And I'm going to list just a sample of example words, terms, phrases to avoid or to think carefully. We had a patient we referred to psychiatry a few months ago. The psychiatrist used the word disheveled. When I went through training in medical school, that's a word I learned, disheveled. And the patient was so upset at the psychiatrist that he was labeled as disheveled that he won't go back to that psychiatrist. So be careful in thinking through describing. One of our physicians wrote this in a chart. The patient comes in full peacock finery. If it's Halloween and the patient meant to do that, perhaps that's fine, but we need to be careful. The use of acronyms, SOB, BS. Patients may not know what we're talking about. Shortness of breath, vowel sounds. Patient refused treatment. You know, these are just words that, the wording that I was taught and I've used for 10, 20 years. I'm now rethinking. And then we had one of our faculty members' husband was seen recently by his primary care doctor, and of course he asked to read the note, and, you know, middle-aged man, and he was described as semi-athletic. He was a little upset. Other tips, address sensitive concerns directly. And the best comment I've heard is discuss what you write and write what you discuss. At VM, the director of their outpatient clinics, after they turned on OpenNotes, she was using the words morbid obesity, and she had a lot of patients complain. And so she started calling it overnourished. I don't agree with that, But I learned from her experience, and now I'm actually using the word obese with my patient. I'm explaining how I calculate it. I'm showing them that I'm typing it in, and my patients are so upset that they're losing weight. So it's working. It's great. Be clear and succinct. Experiment. Try and get patient-friendly notes. We don't have it in our adult medicine clinic. A patient comes in with ear pain. I diagnose earwax. I give them Debrox. It takes me 1 minute. The epic note is 8 pages long. So we don't yet have a patient-friendly note, and I wish that we could take back the note so it's helpful to us as well as the patient. Final tips, encourage patients to actually read these. And this may be helpful in our interaction and relationship with them, and that we can proactively then address any confusion or anxiety they might have. Be familiar with how to amend notes. I have not had this experience, but I hear from people at Harvard, where it happens all the time, that patients will come in and say, oh, it was my right leg, not my left. You know, this is simple. Just say, well, then let's pull up the note and I'll add an addendum, and the patient can see you do it. If a patient comes in and really is upset about what you write, this opens up the ability for us to communicate with them about our clinical reasoning and why we feel as their doctor that this was important. If they're still upset, we can offer to write an addendum and write what they want us to say as an addendum in their voice. And then finally, we're a learning environment. So I think we ought to ask for feedback from our patients and see how we can do a better job. Let me summarize here. I've covered the history of medical records, and as records have grown, they've taken on more responsibilities and roles and purposes. I'm a little worried that adding in the patient, I don't want this to dilute the purpose of our medical record. It needs to maintain its integrity and be helpful for patient care. Perhaps we can alter it slightly so that as we move into this era, it can be helpful for patients. But I want to make certain we maintain the integrity, or perhaps regain the integrity of the records to help patient care. For the OpenNotes research, you saw how short that segment of my talk was. There's not much data. It is limited, and there are a lot of limitations. We don't know if OpenNotes really helps patient care. We don't know if it helps improve compliance. We have self-report. But the third point is that OpenNotes is here in practices. I mean, you saw how we went from 19,000 patients to 5 million. It is spreading rapidly. And finally, I think the future is just amazing and a little scary. I told you how I want to study in our notes where patients come in and write parts of their notes. This is already being done. In Kansas, one doctor in his clinic, the patients email in advance their history of present illness before their outpatient visits. A rheumatologist in his practice has a patient come in and fill out probably 3/4 of the entire record for that day. So I think it'll be interesting moving forward. I began with the patient voice, and I'd like to conclude with the patient voice. This is a video of Harborview patients and their doctors. It is 3 physicians, Sarah Jackson, Bob Harrington, and Shrisha Danareddy. And I want to conclude after this video
a place where
and thank the doctors and patients.
Tell you, patients don't ask the doctor anything. You know, he tells you, and you go for it. And so you're sitting idle. The generation after us, they're asked more questions. They want to know more information, and that's why this system is really critical.
Because verbal communication is a tricky thing, and I think a lot of times, because we're trying to speak so quickly and cover a lot of territory, it's nice to have something that is concrete and written down, I think, to look at.
You can look at the comments that Bob writes down, and sometimes, you know, you agree with him, sometimes you don't agree with him, but that's the way it is. And, you know, I know what's right for me, and Bob knows what's right for me, and sometimes they clash in that, and then Bob and I talk about it, and it works out. We work things out.
I wish I could read more notes. You know, I wish I could read the therapist's notes. And, it's very, very good for me because I've learned a whole lot about my own body since we've been doing this. Like I didn't understand how cholesterol affected you or how liver functions worked.
I have noticed that you're much more interactive at visits in terms of asking questions about what particular terms mean and what prognosis is for things and specific treatments for things like your hepatitis, which you hadn't been really interested in talking about before.
You've gotten more voluminous with your comments. And I actually see it get better because there was more information in this one than there was in the beginning ones. I think we're both learning to use the study. We're communicating with each other across the line. Usually you walk in, you walk out of the doctor's office, and you know it's the next patient, and we go back, and it's over and done with. So this is a more engaged, overall engaged relationship. It's a completely new kind of relationship, doctor and patient.
You and I used to share information when I would go to your office without OpenNotes. OpenNotes is just like the period at the end of a sentence, okay? It helps me understand what you're doing because I didn't have major surgery, but I know what's happening with me, okay? So, how about that?
Thank you very much. I would be especially interested if there's anyone who is an OpenNotes user that wants to add comments. Steve?
Joanne, that was a fabulous talk. Thank you. And as you mentioned, I think the VA's had Blue Button for almost 5 years now. I would say, actually, this is wonderful, but a small baby step. And I just will reflect on a question one of our developers asked me in a taxi cab a few months ago as to whether I thought patients should be able to look at their records. And I said, well, I'm not sure that's the right question. The real question is whether patients will let us look at their records. And I think really what we'll see, I'm going to predict in the next few years, is that actually, this is whole predicated on the notion that we own the record and we allow the patient's access. I think what's going to happen with interoperability is the patients will own the records and will have to request access. And I think we should start thinking in those terms because that's really what will empower patients is to actually, have those records, possess them, and be able to take them to other providers and share them and actually determine what they want us to see and what they don't want us to see. So I think this is a great start, but I think it's just the sort of very beginning of record sharing.
Interesting perspective. With HIPAA, the records, patients need to get access to those records. I was saddened to see that patients in all of the UW system, they have to trek over to Harborview to request their copies of their medical records if they want a hard copy for themselves, and they have to pay 26 cents per page. You can imagine how expensive that gets for patients. So it's a whole new era. They can just get it all electronically. Well, they're going to be. They're going to have them on their wristwatch soon. Cameron in the back.
When will the Seattle Cancer Care Alliance join the OpenNotes?
Good question. The question is, when will the Seattle Cancer Care Alliance join OpenNotes? And I'm looking at Tom Payne. Do we know? Tom is our head of IT.
Well, we don't know yet. It's being discussed. One of the reasons that we chose the outpatient clinics that first place to go was that we do under there we have a portal that we use technically. And the SNCA is just beginning to use their outpatient system. So there's some technical reasons that they weren't involved in the first place. They're discussing. Once you heard any Anderson,
Right. And in fact, when we did the OpenNotes study, it was at the request of the SCCA that while our notes were open to these patients, if they were seen at the SCCA during that study, those were not open. And that was at the request of the Seattle Cancer Care Alliance. So we don't know when the SCCA will open the records to their patients. But as Tom Payne pointed out, MD Anderson, their cancer patients for a decade have had access.
I hope it happens soon.
Thank you. Up in front here.
Do you have information on time utilization and productivity yet?
Oh, great question. That's my big worry, time utilization and productivity. By physician report, they're spending a little more time thinking about what we're writing. That may be good for the records, but not good for us. And it has not yet been studied. And I think it needs to be, so that's why it's good Tom Payne is here, because he can get that data for us. Thank you. Cameron in the back.
I hate these things. So I think that I'm really excited to see the results of your notes, and as someone who's going into community-based primary care, I think a lot of people all over in Seattle are thinking about how we all deal with the burden of the electronic medical record on us. And I think it's nice to see that in some ways it's not all burdensome, that it can actually facilitate communication with patients. And I will say that when I got your initial survey as an R2, I was like, oh my God, this is the last thing I need to have to think about what I'm typing in my notes and learn medicine. And, but, I think it has been beneficial, and one of the things I've taken away from this is that when I write those patient instructions at the end now, I write them with the patient with me so that, because ideally I think going forward, the patient would write their own patient instructions, right? That's the teach back. If the patient could type in what they took away instead of me typing in what I took away for them to look at later. I think so I'm actually excited about the direction this is going for patient care, and maybe this will help us in primary care get beyond this burden of Epic. And I do want to say, speaking about the SCCA, that I think the other thing this can do is to break down the barrier of information between patients and physicians, because just yesterday at the SCCA, I saw an instance where the patient's very first question was, what did my CT scan show? I already knew that CT scan wasn't good, and the provider knew that. But we had to go through kind of the rigmarole of the visit to, get the information and get the exam and pause the thing that the patient most wanted to know. And I think it'll be very interesting if the SCCA opens up their notes to see what impact that has on patients.
Thank you for your suggestions, by the way. I must say that for a while I thought it was just me. I'm the older generation. This scares me a little. But to hear that, our chief resident and some of our residents also realize that this is impacting them, and even if they've just been through medical school 2 or 3 years ago, that we aren't prepared for this. I want to add another comment, which is, you said the patient asked about their CT scan. OpenNotes really is open everything. So patients, they can read our note, but they can also click on the radiology report, and they're going to be reading these. They can click on the laboratory and the pathology, and they're going to wonder, what does atypical ductal hyperplasia mean? Ductal carcinoma in situ. So I think it's not just our department that has to sort of think through, since this is already happening. It's the other departments as well. So thank you. Cameron, up in front.
Nice talk, Joanne. I'm really glad you're talking about this. I'm David Dale. I'm particularly interested in the whole record, though. You just mentioned about the laboratory and other measurements, because patients can be engaged so readily in longitudinal record keeping, blood pressure, blood sugar, and lots of other measurements, and they're interested. But I wonder if you have begun to study that. That is, how you communicate about laboratory data, or PAP tests, or whatever, on a longitudinal basis.
Wow. I'll leave it to our prior dean to ask the most challenging question: how to communicate about all of the subspecialty areas. Since we've done research in OpenNotes, we're now being contacted by faculty in our med school and nationally that want to do research on this. In dermatology, we've had a brief article describing what OpenNotes is and warning the dermatologists that this is coming. They use all the Latin for their nice descriptions. I'm working with pathologists, and we're trying to get them to simplify. In other words, in the diagnosis of skin biopsies of melanocytic lesions, there are 57 different terms. And I'm trying to get them to just say, can we just put on your path report that it's either normal or atypical but not cancer, or cancer? That would help both the internist and the patients. And so I think all of us are trying to move towards clearer communication, but we're certainly not there yet.
Joanne?
Yes.
Excellent talk. It's really great, I think, for patients to be able to get in and look at their record. And you commented earlier that one of the questions or thoughts one of the patients had was being able to link in our note to some credible web information.
Yes.
And is that being worked on? Maybe just the diagnoses are hyperlinked, and then they could go to, they could click on a diagnosis, ductal and carcinoma in situ stuff.
A simple suggestion, let's have a hyperlink. Maybe even the students would need this also for the records. There is a lot of incorrect information available on the web. patients realize that they may be led astray, we may be creating more harm. And the answer is no, we don't have that capabilities yet, but Tom Payne and a few people in bioinformatics are looking into this. Tom, any positive words on this?
My experience, which is you mentioned, has gone back to the health. So I've been doing this with my practice for over a decade. That's an important part of my conversation with them because there isn't one source. So I often bring that up and I put that in my patient instructions. It is tricky to know what one source you would turn to for the broad reach of questions that might come out of an encounter. There are some links that are going to become available through the eCare portal that they use, but it's not as mature as it should be. Paul?
I was just going to comment that this CRAMES patient information that we have available in both ORCA and EPIC is also, there's a sort of a patient-facing version of that that's going to be part of the eCare portal in the month or so. I mean,
it's coming.
Yeah.
In other words,
it's patient-friendly language. It's not customized, I would say, to our highly specialized practice, but it does represent kind of a standardized patient-friendly language that's easily accessible from the portal.
Right.
It won't be hyperlinked, but there will be, they can access that trace.
Okay. I think we have time for just one final question.
How do you deal with the problem of confidentiality? I see part of my obligation to patients as a keeper of secrets, if you will.
Okay.
And when patients tell me that they have high-risk sexual behavior, that's a secret that I keep. I use it medically to protect them, but they don't want that in their records. And open records like this, I mean, everybody knows the NSA reads this stuff. So, I mean, they're reading their emails, guys, so they're certainly reading medical records. So how do you deal with that?
Okay, the question is, how do we deal with all the confidential things that patients may be uncomfortable having in their charts? And sort of privacy issues. Number one, I was caught off guard with how many patients actually shared their login. And we need to train patients to say, this is your responsibility, not ours. You need to be careful. I think here at the UW, we need to develop a separate portal for caregivers. The patient can have access, and if they ever want to block that person, access to their records, but their caregivers should be able to access their records. So I think we need to get the aid of the patients in securing their passwords and privacy. In regards to what is actually in the notes, I was surprised here that psychiatry wanted to use OpenNotes, because at other sites, the psychiatry departments don't. They feel that it will be helpful. I was also surprised when I heard that our sexual trauma clinic was going to go OpenNotes. If we as doctors feel it will be harmful to the patient, we can block it. And I think this also brings up the fact that if we're writing it, we should probably talk with the patient about it. So I want to close by just thanking the Harborview faculty for supporting this and teaching all of us, and for our patients. Thank you.